Electrolytes. So electrolytes, by definition, are substances capable of carrying an electric charge. There are two types. We have anions, which are a negative charge, and they migrate toward an anode. And then we have cations, which are positive charge, and they migrate toward a cathode. The functions, so a volume and osmotic regulation, that is by sodium, chloride, and potassium. Myocardial rhythm and contractility is done by your potassium, magnesium, and calcium. And enzyme activation as cofactors is magnesium, calcium, and zinc. These are necessary for acid-base balance, so bicarb, potassium, and chloride for your coagulation, so calcium and magnesium, neuromuscular function, potassium, calcium, magnesium, and glucose use, magnesium, and phosphate. Water and electrolyte distribution. So water content of the body is between 40 and 75%. It is less in women than in men. Water is distributed in two main compartments as an intracellular and extracellular. Plasma is approximately 93% water. And the concentration of ions in cells and plasma is maintained by active transport, which requires energy, and diffusion, which is passive movement, and it does not require any energy. Osmolality. So osmolality is the concentration of solutes per kilogram of solvent, measured in milliosmoles per kilogram. Increased osmolality stimulates the sensation of thirst and ADH, which is the antidiuretic hormone secretion. So ADH is secreted from the posterior pituitary gland. ADH increases water reabsorption in the collecting ducts of the kidney. Osmotic activity is mainly due to sodium, and sodium concentration regulates the blood volume. Excuse me. Water excess leads to polyuria or excessive urination, which may be due to polydipsia from excessive drinking or thirst. Water deficit activates the ADH secretion and thirst mechanisms. And then the thirst mechanism helps prevent hyperosmolality, which is a high solute concentration, and hypernatremia, which is high sodium levels in the blood. Blood volume is regulated by sodium and water balance. The renin-angiotensin-aldosterone system responds to decreased blood volume. Renin secreted by the kidney is released in response to decreased renal blood flow. Renin converts angiotensin, which is produced by the liver, into angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 in the lungs.
Juicy.
Sorry for that. Angiotensin 2 causes vasoconstriction to increase blood pressure. It also stimulates secretion of aldosterone. Aldosterone increases retention of sodium and water, and then this leads to an increase in blood volume. So that cheeseburger on the slide is actually just an ad from the video that's on there, so yours probably looks a little different, hopefully. But go ahead and take a look at that because that explains this renin-aldosterone system pretty well. Urine osmolality and measurement. So urine osmolality decreases in people with diabetes insipidus and polydipsia. Urine osmolality increases in people with syndrome of inappropriate ADH secretion and hypovolemia. Specimen handling, so if they have a turbid specimen, we need to make sure we centrifuge those before we try to analyze because that could cause erroneous errors. We also can use a freezing point depression osmometer for this. So the sample is placed in a cuvette in the osmometer. The sample is then supercooled, and seating initiates the freezing process. The freezing point is measured, and then the osmolality is reported in milliosmoles per kilogram. There is a video here that explains how to do a calculated osmolality. I also have the equation there as well, and it's really just plugging in those numbers. But the osmol gap, so it's the difference between the measured osmolality and the calculated osmolality. The reference range for serum is 275 to 295, where urine is 300 to 900. Electrolytes, so that includes sodium, potassium, chloride, magnesium, calcium, phosphorus, and bicarb. They can identify as an intercellular or extracellular in either cation or anion. So I made a little chart down there for you that kind of helps differentiate which is which. Sodium. So it's the most abundant cation in extracellular fluid. Sodium is the predominant positively charged ion outside the cells. It plays a critical role in maintaining fluid balance. It determines plasma osmolality, so the sodium concentration directly influences the osmotic pressure of the plasma, which helps to regulate water movement between body compartments. It's also involved in the sodium-potassium ATPase pump. This pump actively moves sodium ions out of cells while bringing potassium ions in. This process is vital for cellular function. It maintains electrical gradients and supporting nerve and muscle activity. Water movement follows sodium. So because sodium is osmotically active, water tends to follow sodium ions and it helps to maintain balance. That affects overall fluid volume. Regulation of sodium concentration. Sodium levels in the body are regulated primarily through water intake and excretion, as well as renal or kidney mechanisms that control sodium reabsorption and excretion. Hyponatremia, so low hypo again, right? Low sodium. So types of hyponatremia based on blood volume. So hypovolemic, normovolemic, and hypervolemic. Hypervolemic hyponatremia is characterized by sodium loss exceeding water loss. The causes can be divided into a couple different sections, I guess. So renal sodium loss, and that can be due to diuretic use, potassium depletion, and aldosterone deficiency. And then we also have extrarenal sodium loss, which could be caused by vomiting, diarrhea, burns, sweating, and potassium depletion as well. And then we also have cellular shift with sodium moving into cells, which can cause a lower extracellular sodium level. Normovolemic hyponatremia, sodium levels are low, but blood volume remains normal. Common causes include syndrome of inappropriate antidiuretic hormone, excessive water intake, and adrenal insufficiency. And then we have hypervolemic hyponatremia. So this is where both sodium and water levels are increased, but water retention is disproportionately higher, which dilutes the sodium concentration. Common causes of this is from renal failure, nephrotic syndrome, hepatic cirrhosis, and congestive heart failure. Hypernatremia causes could be due to water loss relative to sodium loss, decreased water intake, increased sodium intake. Mechanisms, so water loss can occur through profuse sweating, diarrhea, and severe burns. Renal loss could be due to diabetes insipidus because the kidneys do not respond to ADH or ADH secretion is impaired. Chronic hypernatremia is often caused by hypothalamic disease. This is commonly seen in adults with altered mental status and infants who cannot ask for water. The analysis of sodium, so sample types, we can have serum, plasma, or urine. A common anticoagulant used is lithium heparin. The measurement method used is ion selective electrode, or an ISE, and that's the most common method used. There are two types of measurements. So you have a direct measurement, which uses an undiluted specimen, or an indirect measurement, which uses a diluted specimen. Comparison of direct versus indirect. So direct measurement is preferred when the specimen is lipemic, so if there's a high fat content, if it's proteinemic, which is a high protein content. And then an indirect measurement can be affected by specimen dilution and is less reliable in lipemic or proteinemic samples. Potential sources of error. If there's a protein buildup on the electrode, it can cause errors in the measurement. Reference ranges for sodium is usually between 135 and 145 millimoles per liter. Potassium. So it is a major intracellular cation. Concentration inside the cells is approximately 20 times greater than outside of the cells. So functions regulation of the neuromuscular excitability. It's essential for the contraction of the heart. It maintains intracellular fluid volume, and it regulates hydrogen ion concentration. So clinical significance for potassium, so severe hyperkalemia, so increased potassium can cause paralysis and fatal cardiac arrhythmias. Hypo or low potassium, hypokalemia, can lead to arrhythmias and paralysis as well. So regulation is going to be regulated primarily by your kidneys. Potassium loss causes can be due to GI or gastrointestinal loss due to vomiting, diarrhea, gastric suction, cancer therapy, sometimes laxative abuse as well. Renal loss, it could be due to diuretics, Cushing's syndrome, hypomagnesia, sometimes acute leukemia can cause this as well. Or a cellular shift can cause alkalosis or insulin overdose. Hyperkalemia causes, it's usually due to an underlying condition like renal insufficiency or diabetes mellitus that causes cellular loss of potassium, or metabolic acidosis because hydrogen moves into cells to be buffered and potassium leaves cells for electroneutrality. So it leaves the cells, goes out to the plasma, becomes high. Same thing with if you have a sample that's hemolyzed, right? That's the breakdown or explosion, as you will, with red blood cells. So if you have a higher concentration of potassium in your cells and now they've burst open, that potassium is now out instead of in. So that's where you get that, falsely elevated potassium level for your hemolyzed specimens. So in hospitalized patients, this is often due to therapeutic potassium that they're giving them. So they may have a higher potassium level because of that. Excuse me. So specimen considerations, serum potassium levels are usually higher than plasma levels, and this is due to the release of potassium from platelets during clotting. High platelet count can cause a falsely elevated potassium level as well. So more platelets equal more potassium released during that clotting process. It can also be increased if you have a prolonged tourniquet use on that arm, or if the patient is clenching their fist for too long. It can cause a localized potassium release from the cells, and that can also falsely increase the levels. Storage of whole blood at room temp leads to a leakage of potassium from cells into plasma, and that can also cause elevated results. And as I mentioned before, hemolysis, which is the rupture or explosion of red blood cells during the blood draw or sample handling, that releases that intracellular potassium that's found within those red cells, makes it come out, right? That can cause your falsely elevated serum or plasma potassium. So clinical implications, these are pre-analytical errors that can lead to pseudohypokalemia, which may mask the true potassium status of the patient, and it can result in inappropriate clinical decisions. Sample analysis for potassium is you have serum, plasma, and urine. Some important considerations, just like I mentioned before, avoiding hemolysis during your sample collection and handling to prevent that false elevation, and use heparinized tubes for plasma samples to prevent clotting. Once again, we will use the ISE or the ion selective electrode for the analytical method. This is once again the method of choice for potassium measurement due to its accuracy and specificity. And the reference range is generally 3.4 to 5 millimoles per liter. Chloride, it is a major extracellular anion. Its function is to maintain osmolality and blood volume. It helps to maintain electric neutrality in the body, and it participates in chloride shift secondary to movement of sodium or bicarb. The key role in the chloride bicarbonate exchange in red blood cells, which is important for your carbon dioxide transport. Chloride abnormalities or disorders. So chloride abnormalities are usually due to the same causes as sodium abnormalities because chloride passively follows sodium. So hyperchloremia is a loss of bicarbonate, which is caused by gastrointestinal loss, renal tubular acidosis, and metabolic acidosis. Hypochloremia is loss of chloride due to vomiting, diabetic ketoacidosis, aldosterone deficiency, and polynephritis. Chloride measurement, so sample type, we're going to do serum or plasma collected with the lithium heparin. Methods of measurement, once again, is your ISE or ion selective electrode. You can also do amperometric colorimetric titration, which uses silver ions to bind with the chloride ions. When all patient chloride is bound to silver, the remaining free silver is detected by an electrode. The time required to titrate is used to calculate the chloride concentration. So the reference range is 98 to 107 millimoles per liter. Bicarb or bicarbonate is the second most abundant anion in the extracellular fluid. Total carbon dioxide in the blood includes bicarbonate, carbonic acid, and dissolved carbon dioxide gas. So measurement of total carbon dioxide mainly reflects the bicarbonate concentration. The function is it's a major component of the blood buffering system. It helps to maintain acid-base balance by neutralizing acids in the blood. Biochemical pathway, so in the red blood cells, carbonic anhydrase catalyzes the reaction, and this conversion allows carbon dioxide to be transported in the blood as bicarbonate. Bicarbonate ions diffuse out of cells in exchange for the chloride ions. This process is known as the chloride bicarbonate exchange or anion exchanger. Renal regulation, so the kidneys regulate bicarbonate levels in the blood. Nearly 100% of filtered bicarbonate is reabsorbed in the renal tubules under normal conditions. In states of alkalosis, where there's an excess base, kidneys respond by increasing the excretion of bicarbonate into the urine, helping to restore acid-base balance. Analysis of bicarbonate specimen is usually a serum or lithium heparin plasma. Specimen conditions should be anoxic, but evacuated tube can be used. Do not remove stopper until you're ready to analyze. Common methods, once again, is your ISE and colorimetric. The reference range is 22 to 29. Magnesium is an intracellular cation. Most magnesium is going to be found in bone, and less than 1% is actually going to be found in your serum and red blood cells. Free ion is physiologically active in the body. It's essential cofactor for more than 300 different enzymes. Regulation is controlled once again by the kidney, and regulation of magnesium is related to that of calcium and phosphorus. Parathyroid hormone, or PTH, increases renal reabsorption and intestinal absorption of magnesium. Magnesium deficiency is commonly seen in hospitalized patients, especially those in the ICU or those receiving diuretic therapy. Some causes of low magnesium can be just because of reduced intake, so inadequate dietary magnesium consumption, could be decreased absorption, so conditions that are affecting the intestines or gastrointestinal tract that could impair magnesium absorption. Increased renal excretion, the kidneys excrete more magnesium than usual, which lead to a deficit. Endocrine causes, so certain hormonal imbalances can increase magnesium excretion. Also drug-induced causes, so medications such as diuretics may increase magnesium loss. Some clinical consequences, so magnesium deficiency can lead to hypocalcemia, which is your low calcium. There is a strong association between hypomagnesium and hypokalemia, with 40% of hospitalized patients with low potassium levels also have a magnesium deficiency. So your clinical significance, it's important to monitor magnesium levels in hospitalized patients, especially those receiving diuretics or with electrolyte imbalances, because magnesium plays a critical role in numerous physiological processes and enzyme functions. Causes of hypermagnesium or high magnesium. The most common cause is renal failure. That's the leading cause of elevated magnesium levels. When the kidneys fail to excrete magnesium properly, it starts to accumulate in the body. Some other causes of increased magnesium is a decreased excretion. So conditions such as hypothyroidism and hypoaldosteronism can reduce magnesium excretion in the kidneys. Also increased intake, so excessively taking magnesium or having an increased magnesium intake can come from sources like antacids, enemas, or therapeutic administration. So therapeutic use of magnesium sulfate is often used to manage premature labor by reducing uterine hyperactivity. It is also used in the treatment of eclampsia to help prevent seizures. To analyze magnesium specimens, we want to use a non-hemolyzed serum or lithium heparin plasma for analysis. We want to avoid hemolysis since the intracellular magnesium is about 10 times higher than the extracellular fluid, which can falsely elevate the results. A 24-hour urine can also be used, but we have to have acid added to the container to help prevent it from breaking down. Methods. So common method for magnesium determination is the colorimetric assay. So Calmagite, formazine dye, or methylthymol blue. We can also do measurement of the free or ionized form of magnesium, and that provides for better physiological relevance. Reference range for this is 1.2 to 2.1. Calcium. So the clinical impact of calcium. So decreased ionized calcium leads to irregular muscle spasms and tetany, which are muscle cramps or spasms due to low calcium. Hormonal regulation. So 3 hormones regulate serum calcium, and that is your parathyroid hormone or your PTH, your vitamin D, and calcitonin. So PTH is secreted, or PTH secretion is stimulated by decreased calcium levels in the blood. Target tissues for PTH action include the bone. So the PTH activates bone resorption, releasing calcium into the bloodstream. Also the kidney. So PTH increases calcium reabsorption in the renal tubules, which reduces calcium loss in the urine. And also intestine. So indirectly, it does this indirectly by the vitamin D activation. So PTH promotes calcium absorption from the gut. And then we also have vitamin D for calcium regulation. Its role is to increase calcium absorption in the intestine. It enhances PTH-mediated bone resorption, which helps to raise serum calcium levels. Then we have calcitonin. It's secreted by your thyroid gland in response to elevated blood calcium levels. It acts as a calcium-lowering hormone. It inhibits PTH secretion and suppresses vitamin D activation. So the overall effect is it reduces calcium levels in the blood. So distribution of calcium in the body, 99% of calcium is going to be stored in your bone. Only 1% is going to be found in your blood in extracellular fluid. So of this, approximately 45% circulates as free or ionized calcium, which is the physiological active form. Ionized calcium. So there are 2 forms of calcium measured. You have total calcium, and that includes both free, which is ionized, and bound forms, which is usually bound to albumin. And then you have ionized calcium, which is just the physiologically active form of calcium. So clinical significance of this is ionized calcium is a more sensitive and specific marker for detecting calcium disorders. It's especially useful in critically ill patients where total calcium levels may not reflect true calcium status due to changes in albumin or pH. All right, so some issues. So hypocalcemia, remember that low calcium. We have primary hypoparathyroidism, which can lead to a low pH, which reduces calcium resorption from bone, kidney, and intestines. Chronic hypomagnesia impairs PTH secretion and action, which results in secondary hypocalcemia. Hypoalbuminemia reduces total serum calcium, though ionized calcium may remain normal. It is common in chronic liver disease, nephrotic syndrome, and malnutrition. Some other causes of hypocalcemia could be acute pancreatitis, vitamin D deficiency, chronic renal disease. It's decreased activation of vitamin D and phosphate retention. Some special considerations. So normal calcium levels are essential for your cardiac muscle function, maintaining adequate blood pressure and good cardiac output. In surgical settings, so during major surgical procedures, ionized calcium levels are critical to monitor because so rapid shifts in calcium can affect cardiac contractility and vascular tone. Measurement of ionized calcium can help provide a real-time assessment of physiological active calcium. In neonates, so at birth, ionized calcium levels are high. Levels will start to decline after 1 to 3 days, and this is a normal transitional process. At 1 week of age, ionized calcium is slightly higher than adult levels. So monitoring is important for early detection of neonatal hypocalcemia. Hypercalcemia, so an increase in calcium. Common causes is primary hyperparathyroidism. Increased secretion of PTH leads to excessive calcium resorption from bone and increased reabsorption in kidneys. Also, malignancy can cause hypercalcemia, so certain cancers can produce PTH-related protein or metastasize to bone, releasing calcium. Calcium analysis in clinical practice involves measuring either total calcium or ionized calcium, depending on the diagnostic need. So total calcium is typically measured using serum or lithium heparin plasma samples. However, EDTA and oxalate anticoagulants must be avoided as they bind calcium and can lead to falsely low readings. Ionized calcium, the physiologically active form, requires collection of anaerobic heparinized whole blood, as exposure to air can alter the pH, thus skewing those results. Urinary calcium is measured using timed urine collections with acid added to prevent precipitation. And the orthocresylphalaenian complex 1 method is commonly used to measure total calcium via a colorimetric assay, while ionized calcium is measured using the ISE. In adults, the reference range for total serum calcium is 8.6 to 10, though values can vary between labs just like everything else. Phosphate. It is an inorganic ion with approximately 80% of the body's phosphate contained in bone. It is absorbed from dietary sources in the intestine and released from cells into the bloodstream and can also be lost from the bone. The most important regulator of phosphate levels is parathyroid hormone, which lowers phosphate concentrations by increasing renal excretion. So in contrast, vitamin D increases phosphate levels by enhancing phosphate absorption in the intestine and promoting phosphate reabsorption into the kidneys. Hypophosphatemia, or a low phosphate, is common in hospitalized patients due to dextrose infusions, nutritional recovery, if people who are using a lot of antacids, and alcohol withdrawals. Hyperphosphatemia, or high phosphate, is most common in people with renal failure. So analysis of phosphate is typically performed using serum or lithium heparin plasma. Samples containing oxalate, citrate, or EDTA should be avoided as they can interfere with results. It is important to prevent hemolysis during sample collection as this can falsely elevate phosphate levels. Phosphate exhibits a circadian rhythm with concentrations peaking in the late morning and reaching their lowest levels in the evening. So for urine analysis, a 24-hour collection is pretty standard. Common laboratory methods for phosphate measurement include the formation of an ammonia phosphomyladate complex, which then allows for accurate quantification. The normal reference range for serum phosphate in adults is 2.7 to 4.5. The anion gap. So routine measurement of electrolytes typically includes sodium, potassium chloride, and carbon dioxide. These values are used to calculate the anion gap, which represents the difference between unmeasured anions and unmeasured cations in the blood. The anion gap is useful for detecting an increase in unmeasured anions and serves as a form of quality control for analyzers. There are two commonly used equations for calculating the anion gap, one without potassium and one with. So without potassium, the calculation is listed there. But why we use it? Because potassium levels are usually low and contribute very little to the overall charge balance. It's simpler and gives a reliable estimate in most cases, and it's used in routine labs and when potassium measurement might not be available immediately. Then we have another equation, which is the one with potassium. This one is used less frequently, but might be preferred when potassium levels are significantly abnormal. So if somebody has hyperkalemia or hypokalemia, and it could help influence the acid-base balance more noticeably. Sometimes these are used in research or detailed metabolic studies. So generally, you're going to use that first equation without potassium. Here is a video on how to actually, calculate it and a little bit more about the anion gap.
Did you